Good afternoon. This discussion will cover material from Chapter 56, the Female Reproductive System Assessment and Management. We'll note that there are a few things that overlap with prior content from earlier in the semester. I'll make reference to that as I move through the chapter. But let us begin now with assessment in the AM, just a gentle review of A&P of the female. The anatomy review would involve structures that you are well familiar with at this point in the semester. Things like the uterus, the ovaries, the fallopian tube, the cervix, the vagina, the breasts, and how they play into assessment. This particular discussion will speak to the non-pregnant female. We've already covered the pregnant female, both prenatal and delivery. So the first thing that I want to draw your attention to in your chapter is the discussion surrounding the menstrual cycle. And your chapter addresses it looking at three particular areas of the cycle, and that is the ovulatory cycle, and that's the changes that the ovaries go through as they move through the cycle and their response to FSH and estrogen. Your textbook also then speaks to the endometrial cycle, which is the uterine cycle, and that is how the layers of the endometrium change throughout the cycle. And then finally, the hormonal cycle, and that is the rise and fall of hormones as you move through the cycle. Again, a lot of this is pathophysiology, and of course we know that questions typically are focused at nursing care, but you have to have a broad, sort of a general understanding of the menstrual cycle in order to understand hormonal activity, some of which you're well versed in, again, because we've studied the effects of estrogen and progesterone on the pregnancy. Bringing your attention primarily to estrogen and progesterone, the estrogen levels during the first few days of the cycle, and that is typically when the woman is menstruating and shedding the lining of the uterus, the estrogen levels will begin to rise. And those levels will rise right up into ovulation. And sometimes as we try and sort of attach meaning to the hormones, the female hormones, estrogen could be, if we were going to identify them as happy or sad or maybe angry hormones, estrogen's a happy hormone. When we have it readily available in our blood, circulating bloodstream, it does relatively help women to have a positive or more of an upbeat feeling. And then post-ovulatory, so once ovulation has occurred and the follicle has ruptured and released an ovum, a mature ovum, the estrogen levels will fall off significantly. And then we start to see the rise in progesterone levels. Progesterone levels are what is needed to allow the uterus to support what could possibly be a pregnancy or a fertilization. Progesterone is the rising levels of progesterone can sometimes for lack of, it's really not medical, but like the angry hormone. And if you think about the female cycle, we know that women oftentimes, when we talk about disorders later in this chapter, can associate or certainly find that there's some of those premenstrual sensations that women feel prior to menses, that they say they feel sort of sad or empty or angry, and oftentimes those are attributed to that surge in progesterone right before the onset of menses. So sort of understanding that hormonal rhythm, if you will, your textbook has a beautiful graph, actually two graphs that you can see where it shows the ovulatory cycle and how it in relationship to the uterus, and then it also on the next page shows you the hormonal graph showing estrogen and progesterone and some of the other female hormones. But if you can get your head around those major concepts, you have enough to move forward and really understand disorders and then nursing management and nursing care. The other piece of just right up front assessment, A&P, physiology, things you need to be aware of, is the fact of menopause. Because if a woman is not, if she's prepubescent, right, young girl, then she's not menstruating yet. Then she enters her menstrual years, which can last for anywhere between 20 to 30 years, 2 or 3 decades. And then the woman will enter to the period what we call menopause, and that's the cessation of ovulation and then menses. So we'll talk more about menopause later in the chapter. So when we talk about the anatomy and physiology of the female and assessment of the female, we should include in our assessment sexuality. So not only sexuality, is the woman sexually active? Where is she at in her sexual maturation or sexual activities? But also her sexual identification, and that would include the lesbian and the bisexual or slash transgender population. And how do we appropriately assess women's sexuality on a curve for throughout the lifespan? Assessment typically includes some routine diagnostics, and that is the onset of the pap smear or the Papillon screening, and that should begin somewhere between 20 and 21 years of age for females, and should be, if they're normal, done every 3 years. If they're abnormal, they're done more frequently. Same thing with mammograms. These are very female specific. Mammograms should begin at age 40, and they should continue annually, and that is the evidence that we're using right now. And then the other female specific exams for assessment would be a pelvic exam, which is examination of all the structures held within the female structures within the pelvis, and then the self breast exam, or the SBE. Again, these are assessments that we make sure that, or we ensure that our female population are receiving, and that we are also assessing. So some notes of high risk since we're doing assessment. And again, sexual behaviors. So it's important to understand a woman's sexual activity so that we can identify if there's risk of things like STIs, sexually transmitted infections, or unwanted pregnancies, or multiple partners, which can sometimes contribute to HPV and then cervical cancers. So these are things that are super important to assess as far as high risk. Family history of any female-specific cancers. In particular, we look closely at breast cancers and ovarian cancers, knowing that there are increased risks when a woman has a first-line or a first-degree female family member who's also had a history of those cancers, whether they've survived or passed on, deceased. DV, domestic violence. Is there risk for violence in this woman's lives? And then access to health care. Does this woman have access to those routine screenings and assessments that are necessary to keep women healthy throughout the lifespan? Nutrition and weight management, and this is inclusive of things like lipid profiles, cholesterol, risk of coronary artery disease. All of those things are kind of encompassed with, is this woman nutritionally sound, and is she able to manage her weight and stay at that BMI, desired BMI, right, of less than 25. If she's greater than 30, it's grand or gross obesity, and we would certainly refer her for support to manage her weight in that respect. And then finally, another area that we have to pay attention to with women is bone health. So I'm going to actually stop right there, and I will return shortly.